Hey, Dr. Dahl, how are you?
There you go.
Oh, you're muted. I can't hear you.
Hello.
Oh, hi.
Hey, how are you?
Hi. What's up?
Got a couple minutes to go and then we'll be ready to start.
Okay, great.
I'm just putting a Facebook post up, so hopefully we'll get a few more people in the room. But either way, we will be playing this recorded talk all through the year leading up to the next 2022 event.
Okay.
Should be good. And we're happy to have you. Thank you.
Thanks for having me.
Of course.
Nobody takes the time off during the week, but a lot of people will watch them afterwards.
Should I try sharing my screen now?
Please, let's do that.
Great. Let me, this is it.
And then I see you. You see me? Okay.
Yep, looking good.
Yeah, so I guess,
Awesome.
yeah.
Let me
no
just
problem. So
paste this
I'm sure
here.
we'll hop on soon, hopefully.
Where's my link
But
to
yeah,
that?
One
And then
thing
I
for
saw
sure,
in the
you're probably gonna
email,
have a mic.
we're doing about 50 minutes, maybe 10 minutes for
And then
questions.
we'll
Is
be
that?
able to record that.
Yes, ma'am.
Okay.
Okay.
Just give me 1 second here, and then I'll get off the sound for you. Oh no, Jenny, what did I do here? I'm trying to put, oh, there it is. I think I got it. That's it. Never mind. Got it. Thank you.
Oh,
just
sorry, I have
wanna-
another question. How will questions be asked? Like,
They're going to come through on the chat and I will sort through them and then I will jump in there towards the end and read you the questions.
perfect. So I don't have to pay attention to the chat or anything like
No,
that.
ma'am. You just
Great.
do your thing.
Great.
Yeah. Yeah, we do that. Yeah.
And then after this is all over and I watch your whole presentation, I'm going to email you with some questions specific to your talk, just because I have a special interest in your field.
Awesome. I made it very like patient and family oriented, but tried to, include research and things like that. So I'd also love feedback if I end up doing this again in the future. Let me know, how you think it went and if there's anything I could do differently.
So Dr. Nordley knows me. I don't care who's listening, really. I'm not saying anything. Dr. Nordley knows me from when he came to Los Angeles for that short stint. Aside from Epilepsy Awareness Day, I do in-home video EEG monitoring. So, and I'm basically focused on the autism community because those are the kids, as you know, that don't get a fair shake at the hospital and generally not willingly admitted. So that's what we specialize in. And I saw patients from CHLA from Dr. Nordley, and I sent him several of our other patients. And I just want to pick your brain on what you're doing as far as treatment, because he specifically said, Dr. Dahl does not warehouse these children. She treats them. So that's important.
Absolutely. And I probably want to pick your brain as well.
Great.
To see if there are different things we can do here. So
Yep, that would be great.
So
All right,
glad to
and you too. I'm going to pop off the sound because you're going to be getting ready to start in a second. And I will pop on as you have questions.
Perfect.
For those of you who are watching, we have Dr. Emily Dahl from the University of Chicago. And she is obviously, as you can see by the screen, giving a talk on autism and epilepsy. This is something that really affects our community. I think people really don't grasp how prevalent this the comorbidity is and the amount of especially children who have both autism and then develop epilepsy later after their autism diagnosis. So with no further ado, here is Dr. Dahl.
Hi, and thank you so much for having me. My name is Dr. Emily Dahl. I come from the University of Chicago, Comer Children's Hospital. And yeah, I'm going to talk to you today about autism and epilepsy. I am boarded in epilepsy, so I did a 1-year fellowship in pediatric epilepsy. And autism is just a special interest of mine. After coming here for about a year now, we've developed an autism and epilepsy clinic. This clinic involves me and someone named Dr. Peter Smith in development and behavioral pediatrics. And so we see patients in conjunction who have a likely or definite diagnosis of autism, and then questions about abnormal movements or possible epilepsy. And so I've devised this talk based on those patients. And so my talk is basically the questions that I get the most and how I answer them. So at the end, there will be time for questions, but I hope this is really helpful. So to start, I don't have a definition of epilepsy because this conference is focused on epilepsy, but I did want to give a definition of autism. Autism in the new DSM, the most recent definition, is basically divided into two parts. It's deficits in social communication and social interaction. And as you can see here, all three of these symptoms must be met in order to meet criteria. So social emotional reciprocity, that's kind of the back and forth. Sometimes parents will tell me if they stub their toe or they injure themselves, the child doesn't necessarily soothe them or worry about their pain. That might be a way that this presents. A deficit in nonverbal communicative behaviors used for social interaction. When kids are young, something that the pediatrician will screen for is called joint attention. And so that's if the parent or someone looks at something excitedly or points to it, children should be able to realize by the age of 18 months, oh, something exciting is happening over there, and look towards it. Patients with autism often are lacking this. And then developing, maintaining, and understanding relationships is pretty straightforward. And then they need two of the following: restricted repetitive behavior, patterns of behavior or interests. The very first one is stereotyped or repetitive motor movements, use of objects, or speech. So as you can imagine, sometimes this can be confused with epilepsy, as epilepsy has rhythmic behaviors and seizures, present stereotypes similar each time. So this is often where the lines can blur and when we see patients, and I'll certainly talk about that more. An insistent on sameness, so wanting to have either the same food every day or drive the same route, to school every day, or, establish a similar routine. Fixated interests, and then hyper or hyporeactivity to sensory input. So patients often do things called stimming, which we'll talk about, where they kind of crave more sensory input, or the opposite, loud noises or increased sensory input can be overwhelming to them. So that's the diagnosis for autism. Like I said, the rest of my talk kind of focuses on questions that I hear a lot. So my child has been diagnosed with autism. How likely is it that my child will have a seizure or will have a diagnosis of epilepsy at some point? And those numbers vary quite broadly. I've seen numbers range all the way down from 5% to up to like 45% based on the studies you see, but around 1 in 5. In the general population, about 1% of people have epilepsy. If you think about patients with global developmental delay, we often see them in our pediatric neurology appointments. Those children are closer to 50%. So this is somewhere in the middle. But just an example of a few studies. These were patients that were diagnosed with autism and then followed out to see if they developed epilepsy in the future. And in both of these studies here, 21% and 22% of those patients went on to develop epilepsy at some point. So the number's somewhere around there. Multiple studies have shown that the more severe the intellectual disability, and specifically the more severe the receptive language disorder is, the more likely patients with autism are to have epilepsy. And like I said, this has been shown kind of time and time again. But one kind of example here, looked at this meta-analysis of 24 studies between 1963 and 2006. 20% of those patients with intellectual disability had epilepsy, whereas only 8% of those without intellectual disability had epilepsy. So this really does seem to be a true correlation, and I've seen it in my practice as well. Interestingly, some studies have shown female gender as a risk factor, but it's not always statistically significant. So it's unclear if this is a true risk factor or something that we've just kind of seen on occasion. So next question I get a lot. My child is 15 or an adolescent, or sometimes even an adult, and this is their first seizure. Why would this happen all of a sudden now? Why would their brain seize at this point in their life? And interestingly, in epilepsy, in autism, there are two main peaks when seizures begin. One is in early childhood, as you might expect, especially very early on before the age of 1. Often people have epilepsy well before their diagnosis of autism. And so that's going to be this age group. And then there tends to be kind of a quiescent period. And then starting in adolescence again, there's another large peak. In fact, the numbers again vary, but up to half of patients might have their first seizure after the age of 10. And several patients might actually have their first seizure as an adult. So when we look at the general population, you can begin to have epilepsy at any point in your life. There are certain syndromes, if you think of like juvenile myoclonic epilepsy, and there are other syndromes that routinely happen in adolescence or young adulthood. And then there is something special about puberty. Patients with epilepsy, sometimes their seizures get worse, sometimes their seizures get better. Women especially, estrogen has a negative impact on epilepsy, can be pro-epileptogenic. So some women or people with uteruses will have an increase in seizure frequency around their time of menses. That's something that's been studied really, really carefully. So in all comers, we sometimes see a peak at adolescence, and epilepsy is no different. So I see this a lot. This one study, this one is kind of an outlier, but I wanted to mention it just because it was interesting by how old the age of onset was in this group. But they studied 192 patients, and the mean onset of epilepsy in these patients was age 13. And you can see in this graph, a lot of patients develop seizures after the age of 10. So if you don't have seizures when you're young, it doesn't necessarily mean you're out of the woods, unfortunately. And it's not uncommon in this specific group for seizures to develop later in life. So I get this question a lot. When I see patients with autism who do not have epilepsy, we always counsel them on what seizures could look like. And the fact of the matter, in autism, they can look like any type of seizures. Children with autism can have any seizure type. And this here is our 2017 classification of seizures, just to kind of remind you, they can look like anything. But particularly infantile spasms are very common in patients who are later diagnosed with epilepsy, later diagnosed with autism. So infantile spasms, these happen in patients, 0 to 12. They typically happen around 3 months to 9 months is usually when they first present. And they're kind of a neurologic emergency in that patients need to get diagnosed and treated right away, because the longer these go untreated, there is a risk of worsening development. These are very characteristic on EEG, and they're very characteristic clinically. The patient will have like a jackknife movement where they extend their arms and flex at the trunk. They're usually irritable in between. They happen more frequently in the morning. And there are certain patients that we know of that are more at risk for these, and we might watch more closely. So patients who have a really difficult insult at birth called HIE, hypoxic ischemic encephalopathy, they're at risk for this, as well as patients who are diagnosed with tuberous sclerosis early on. We counsel them very early on about the risk of this seizure, and we often actually check EEGs even before they have signs of this to see if we could curtail this on the early end. But usually this was kind of retrospective. A patient's diagnosed with autism later in life, and in the past, they had these infantile spasms. The most common seizure type is focal impaired awareness seizure. And so focal onset, meaning coming from one part of the brain, and impaired awareness, meaning they're either completely impaired and have no idea what's going on and are unresponsive, or at least their impairment awareness is altered and they're kind of confused. These can look, as you see here, many different ways. Just to talk about a few of the words, automatisms is when a patient might kind of fumble or do something non-purposefully with like their clothes or their blankets or some object nearby. And then myoclonic, because that one's actually relatively common in autism, are like rapid jerks of one body part, like the neck or the shoulder or hand. We see those quite commonly. And then really commonly, it can just be staring and arrestive behavior. And so staring spells is something we really commonly see in autism. And the main question is, could this be seizure, or could this just be a staring spell that's kind of behavioral? And I'll talk a little bit more about that. This one study I found really interesting. We often don't capture seizures on EEG in children with autism because it's hard to hook up an EEG if it's really upsetting to the child. Some kids with autism, it's really difficult to put the EEG on because they don't like the way the electrodes feel on their head and you're messing with their head. And so this study was really cool because it went back and looked at patients with autism who had seizures captured. And interestingly, it was about half and half who had focal seizures only or generalized seizures only. Focal meaning starting one part of the brain, generalized meaning the whole brain at once. So certainly both can happen. On EEG, you can see both these types of seizures or the interictal discharges, the spikes, can appear either focal or generalized. And then very importantly, I always counsel my patients on this. If your child has a regression or decline in any sort of development or performance, so all of a sudden they're speaking less, or they're not doing as well at school, or they're sleepier, or something changes and that's persistent, talk to a neurologist, because we might want to check an overnight EEG. Sometimes we find seizures at night that we don't know about any other way other than the child is having a regression. So I always counsel on this and always ask about this. And it's important to bring up if you've noticed this, because we might want to do an overnight EEG for them. Another question I get asked a lot. My child often looks out of the corner of their eyes. Is this a seizure? You may recognize this if your child has autism or someone you know has autism. It's a really common thing that children with autism do, and it can be mistaken for seizure. So this is a patient will kind of look out of the corner of their eye, but have completely maintained awareness. So they're still running or interactive or playing. They might do it many, many, many times a day, and they might be more likely to do it if they're either really excited or they're in like a stressful or anxiety producing environment. And this is typically an example of what we call stimming, self-stimulation, which can be, you can see it a lot in autism, and we'll talk a little bit more about ways you might see it from a motor standpoint, but you can also see it from a visual standpoint. So children might stare at objects that are rotating or spinning or light up. A lot of times they'll kind of bring the object that lights up right to their eyes, and it kind of feels good to them to see those lights right in front of their eyes. They might blink repeatedly or turn the lights on and off. They might move their fingers in front of their eyes, which kind of does the same thing. It alters the light and dark. Or they'll put objects in a line and kind of squint down and look at the objects. Those are all examples of visual stimming. And these aren't usually confused for seizures, but out of the corner of their eye, that one often is, just because seizures can have what's called gaze deviation, where a patient looks really hard in one way or the other, and it can't be overcome. But that's usually also associated with some other symptoms of seizure, like stiffening or jerking on one side, loss of awareness, behavioral arrest. And so usually we can differentiate these two. The gaze deviation usually lasts longer, and usually they're tired afterwards. While this kind of stimming example, they just look out of the corner of their eyes, they're back to normal afterwards, they're completely engaged during it. And as to why people will do this kind of stimming is it either helps them when they're overloaded with sensation, or the opposite. It feels good to add this kind of different stimming sensation, or they might feel anxious and it's like a self-soothing. And then the other most common question we get a lot is, my child has staring spells, are they seizures? And this one can be very difficult to differentiate. We always start off gathering the history and asking the patients or the parents about what these staring spells look like. We often get an EEG, and sometimes we even get an overnight EEG. And I'll talk a little bit more about like the EMU admission for overnight EEG and what that entails. But if we're confused, the best way to answer this question is to capture one on video and on EEG, so we can look at it and say, okay, now we know pretty much for sure this is or isn't a seizure. But when they are seizures, there are important things that we'll always ask about. So how long do the staring spells happen? These two different seizure types, absence is a generalized type, focal is coming from one area of the brain, and that's kind of on our differential. Is it this, or is it just kind of a behavioral staring spell? Absence seizures last about 5 to 20 seconds. They happen many, many, many times a day. Some patients will have these up to 100 times or more every day until they get on a medication. These typically start around the age of 4 to 8 years, although patients with like something called the Lennox-Gastaut syndrome or a more severe epilepsy can have an atypical absence that starts later. There may be associated movements with it, meaning your eyes might look upward. You might fumble with your hands at the center and the midline. and you might have eyelid flutter. Afterwards, there's an immediate return to baseline. It's as if the event never happened. The patient continues doing exactly what they're used to. And then the EEG is almost always abnormal in both atypical and typical absence. We see generalized discharges, and even if you get like a 40-minute EEG, it's very rarely normal if the patient is not on medication. Focal seizures, on the other hand, typically last a little longer, more like 30 to 90 seconds. The frequency is variable. When untreated, these might happen every day, or they might happen once every several months to a year, but they're not happening, many times a day, like the absence seizures do. Onset can happen at any age. This can happen in the NICU when patients are first born as a newborn up until adulthood, and can be caused by many different things in the brain. The associated movements with these, if there are movements, there's a lot more than I listed, but as opposed to eyes looking up, they'll usually look to the left or the right. You may see something on one side of the body instead of at the midline. It's only one hand is fumbling with something. And you'll often see unilateral motor as well. So either jerking or stiffening or something like that. Sometimes you'll also see things like lip smacking. There's a lot of different movements that we'll always ask about that come along with it. If you see any movements during the staring spells, it's so helpful to tell your doctor about it. Afterwards, patients are usually tired. It's not usually a quick return to normal. They usually are very sleepy, are not as engaged afterwards, and often need to take a nap. And then on EEG, we should see something focal, either slow activity or discharges, but the EEG can also be completely normal. So the EEG can be really helpful in differentiating these staring spells, but this is kind of a thing to think in your mind when you see them, and certainly to let your doctor know if you have questions about these. So what is a stereotypy? I talked a little bit about kind of stimming already, but stereotypies are, I put purposeless in quotation marks. It's seemingly purposeless. They're not movements that are getting you towards something, but children with autism who do this, it might be to self-soothe in like an anxious environment, or to add sensory input when they're feeling kind of depleted of sensation. So purposeless to the naked eye, but the patient might feel a purpose with it. But they're repetitive and invariant or stereotyped movements. They're typically rhythmic, and they can involve any part of the body. They can be heterogeneous amongst one patient, and certainly heterogeneous amongst all patients. So common examples, you might think of hand flapping. That's the kind of one people often talk about with autism, where children will get excited or nervous and they'll flap their hands. I always think, then this kind of dates me, but I always think of Wallace and Gromit with this, if you've ever seen that. But he loves cheese, and whenever he talk about cheese, he'd do this with his hands, and he'd go, "I love cheese, Gromit." And I tell patients about that because that's a reminder that if you have a stereotypy, it doesn't mean for sure you have autism. A lot of children have stereotypies and grow out of them. A lot of adults even have autism, like Wallace. But children with autism have them far more commonly than other people. And children with autism often have them more severely, more frequent, and they're less socially appropriate. So they could even, involve head banging or something like that has a social stigma. Rocking of the body back and forth, walking on the tiptoes, looking at spinning objects or bright lights, and like I said, lining up or running objects across the peripheral vision. They're often triggered by some sort of feeling of excitement or anxiety, but they don't have to be, and they can happen all day long, and they're usually stereotyped for the patient. These are not seizures, though, and to help differentiate them, there's no change in consciousness. They are always completely alert during them and can kind of go back to playing as they normally do. And because they're repetitive and we see them a lot, we often encourage families to take a video recording of this when you see it. If there's any question, could it be seizure? Because when we watch the video, we may pick up on something really subtle that you didn't pick up on necessarily, or you didn't think to look at, that makes us think, oh, this is more likely seizure or less likely seizure. But sometimes they can really, the line can kind of blend. I had an infant who, she was like maybe 9 months old or so, and all day she'd go like this. And the parents were really worried that was seizure. But sure enough, we got an EEG and it was normal and everything. And that was a stereotypy, and she never went on to develop autism. But sometimes they can also have like jaw clenching or stiffening, and they can really be perplexing. Is this a stereotypy or is this a seizure? And we might want to get an EEG or bring them in for an overnight EEG and capture one of these if we're not sure which this is. So if it isn't a seizure, what else are we thinking of? My child has an abnormal movement, or we've noticed something abnormal. You're saying it's not seizure, then what is it? Could be stereotypy, like we just talked about. Especially with staring spells, it's often behavioral. So the child might be overwhelmed with some sort of stimulation, and they're just kind of shutting down and they can't really take anything else in. They might just be distracted and kind of ignoring mom calling their name or something. Or it could be because there's ADHD going on and they're having trouble focusing, or they're distracted. Or maybe a lot of children with autism have difficulties with sleep. Maybe we're not getting good sleep at night, and so we're distracted, not paying attention during the day. There's a lot that kind of goes into this behavioral category. Stereotypies is a common one. And then, like I told you before, we always want to know if there's any regression or decline in development, but that happens in autism sometimes. So if we get the overnight EEG and we're not seeing nocturnal seizures or frequent epileptiform discharges, we might be able to attribute that to the autism itself. Another thing we ask about is daytime sleepiness, or sometimes patients will kind of out of the blue start wetting the bed. That might be another reason to get an overnight EEG, either in the hospital, or sometimes the EEG can even come to you in the home. And if we don't see EEG, seizures or epileptiform activity, it might be because the patient isn't getting good sleep for other reasons, and we have to evaluate their sleep. Less commonly, it could be movement disorders. Patients with autism can have movement disorders. Tics are common in all children. So these are movements that they're kind of on the realm of voluntary and involuntary. They often start in the head. So they might have like blinking, repetitive blinking, or grimacing, or twitching of the head or shoulder or neck. And these feel a little bit uncomfortable until the child lets them out, and then they feel a little bit better about them. So there are other movement disorders that we may end up diagnosing if we see abnormal movements and we decide they're not seizures. Certainly stimming, like we talked about, and then sleep disorders, or often we'll find out it's some sort of pain. If the patient's doing something repetitively and is unable to talk or communicate fully, you always want to look at, is there something else going on, especially if this is new onset? Are they having headache? Are they having belly pain? Is there something that they can't really describe to you due to impaired communication? So something to think about, especially if it's kind of new onset repetitive movements. All right, so I talked to my doctor about these staring spells or abnormal movements, and they said, because you have autism, you're at greater risk for seizures. We got the routine EEG. We're still not sure. They said we have to go to the EMU. What does that entail? So the EMU admission, typically there'll be a scheduled admission where the patient already knows ahead of time they're coming in. And as you can imagine, it might be kind of traumatizing because we're going to the hospital. This is a new place. We're going to stay there overnight. They're putting all these sticky electrodes on my head. So there's a lot you can do to prepare for it. Ask your institution about child life. Child life can be absolutely amazing with this group, and they can come up with things ahead of time that will soothe the patient. So different institutions might have lava lamps or soothing music or other sensory toys. And often child life will come by with like a tablet or another sensory toy to help explain the procedure to the patient if their communication skills are at that level, or at least help distract them and soothe them during the process of hooking up with the EEG leads. It's not painful by any means, but it certainly could be disturbing for someone who has sensory processing concerns. And then prepare beforehand, depending on your child's level and what might be helpful for them. You can consider doing social stories or showing pictures beforehand, talking to them. Your institution might even have like a teddy bear or fake little things that you can stick on the head and explain about the EEG leads. This is, of course, child dependent, but some people do better if they kind of know what to expect ahead of time. and you inform them, we're going to stay overnight. We're going to put stickers on your head. It's going to be one day and then you'll go home the next day. So there's not that fear about this new environment, because that will make the hookup more difficult and can be a little bit more traumatizing. We don't want to sedate the patients to hook up the EEG, but we can. The reason we don't love doing this and we try to do it without is it can alter the reading of the EEG, can kind of obscure some abnormal findings. And also, if patients need the sedation for the EEG hookup, sometimes it means as soon as they wake up, they're going to rip the leads off. So something to ask about, but usually people want to try to do it without sedation first. Always ask in advance if your child already has epilepsy and is on anti-seizure medicine, are we going to wean the medicine beforehand? And are we going to need an IV? Rescue medicines can be given in the nose or in the rectum, but often, especially if there's a medication wean, they want to do IV placement. And so it's good for you to ask beforehand so that's not a surprise. And then very importantly, there are options for what's called ambulatory studies. So we often like to do, if we can, we like to do these EEGs in the hospital because it's a controlled environment for us. So we can move the camera, we can come in and test the child immediately at the time of the seizure. We have rescue medicines available, but it's not the typical environment for the child. And so, especially in children with autism, if parents think this is a no-go, or if we try it and it's really traumatizing, then we consider doing it in the home. There's still the EEG hookup, which can be, new and different for the child, but at least they're in their own home to do this. And you can have a video EEG at home, and the parents can kind of move the video and keep the child kind of in one room. And so we can actually see the spells. And this is often a nice kind of in between, where if we can't get them into the hospital, we at least can get some really good data at home. So ask about that as well. Depending in either way, if you do it in the hospital or at home, think about triggers for the spells that the child has. So if the staring spells always happen when they're watching their tablet, have them watch the tablet, bring the tablet to the hospital with you. If they happen while the child's doing homework, bring homework. Anything that you can think about that will trigger it in the hospital room, think about that ahead of time. And very importantly, if you see a spell, push the button. I always tell all my patients this, but sometimes people forget. Push the EEG button if you see anything concerning for seizure, because it marks the time right on the EEG for us. It's very helpful. All right, so we did an EEG. Maybe it wasn't overnight, maybe it was a short one, but the doctor says it's abnormal. What does that mean? It can mean something, or it can not be very helpful. The reason why I say that is children with autism are more likely to have abnormal EEGs than the general population. And so this can sometimes be kind of confusing to interpret, and sometimes can lead on a diagnostic odyssey to figure out, why is the EEG abnormal and what does it mean for my child? So in typical patients who've never had a seizure before, but might have a family history of seizures, about 2 to 3% of EEGs might actually be abnormal with no higher risk for seizures at all. In the autism population, that number is much, much higher. 10 to 72%, that's a very wide range, but basically it's a high number. A lot of patients with autism have abnormal EEGs, and sometimes they never have a seizure. And so that can lead to difficulties interpreting this. This one study looked at 32 patients. All these patients had come into the EMU, that epilepsy monitoring unit that I was talking about, because they had some abnormal spell, maybe staring spells, maybe jerks in sleep, what have you. They came in, and all of these patients ended up having an abnormal EEG. And 15 of those patients had their event captured. Again, it was mostly staring spells, but some of them had issues in sleep. None of those patients, of the 15 patients who had their event captured, none of them were seizure, but 11 of those 15 patients had spikes on their EEG. So it's difficult to interpret. If you capture the spell, then that's helpful. If you don't capture the spell, then the question is, okay, how concerned are we that these are seizures? Because that helps you decide, do we need to treat them or not? There also needs to be more research about this in general. And so this is a big interest of mine from the research perspective. But if we see these abnormal discharges, what does that mean if it doesn't mean epilepsy? Is it possible that these discharges are contributing to the condition itself? Is it possible that they're affecting cognitive development and causing, difficulties? Do they need to be treated? And then, like I said, are they related to the spells in question? As of right now, we don't treat an abnormal EEG if we're not sure that they're seizures, but this certainly requires more evaluation in the future. And so for this reason, another question I commonly get is, okay, we've been diagnosed with autism. Do I need an EEG? And if we don't have concern for seizures, typically a screening EEG is not recommended, because if we see that it's abnormal, then we come to the question of, do we need anti-seizure medicines? And it can be a little bit hazy. Every once in a while, the EEG can give us a really good clue into the underlying cause of autism. So this is one example of something that actually has a kind of specific EEG finding and might lead you to a diagnosis if you hadn't tested this already. Now, the recommendation of the American Academy of Neurology, Child Neurology Society, American Academy of Pediatrics, everyone agrees if a patient is diagnosed with autism, they should have Fragile X testing done, particularly if they're male. So hopefully this has already been done, but not necessarily. Fragile X syndrome is something that's X-linked. So it's on the X chromosome, and it's a mutation in this gene called FMR1. Things that are X-linked are more likely to affect males than females. And so we much more commonly see this in males, and males are more severely affected, but females can also have this diagnosis. Patients have intellectual disability, often have autism. They have large ears and testicles, and they have speech and language delay. And about 1 in 5 will also have epilepsy. The reason it's important to check, it's the most common inherited cause of autism. And on EEG, you don't always see this, but they often have these very particular types of spikes that are in the central and temporal regions of the brain, and they look a very specific way. And so if we see this in a patient that does have autism, it might make us think, could this be Fragile X? And have we tested for it? And if not, we should test for it. Another one where the EEG might actually tell us something about the patient is called Angelman syndrome. There's a few different ways this mutation can happen, but it's a loss of the contribution from the maternal side on a certain chromosome 15. It doesn't necessarily mean it comes from the mother. It can happen what's called de novo in the patient, or it can be a mutation in this gene, UBE3A. These patients have developmental delay, often have autism. They can have dysmorphic features. They can have ataxia or incoordination. They're often very happy. They may have kind of inappropriate laughter at times, and most of these patients have epilepsy. And very commonly, their EEG looks like this. This is called notched delta. Delta just refers to how quickly or slowly you see the pattern across the page. So a delta is the kind of, I can point here, it's this kind of big, slow rhythm that happens 1 to 3 times per second. And the notched part is that we see little spikes at varying points around that delta. This is not specific for Angelman syndrome. We can see it in different types of epilepsy, in different genetic disorders, but it's very, very commonly seen in Angelman syndrome. And this EEG is actually from one of my patients. He is a 3-year-old male who has autism and low tone hypotonia. And we had done a pretty good diagnostic workup, but I never looked for Angelman's in him until I saw this EEG. And then we did test for Angelman's and he had it. So in this case, the EEG actually helped provide the diagnosis for the family, which is helpful in genetic counseling and helpful in which anti-seizure meds you pick, as well as kind of talking about prognosis. So this is one of those times the EEG was actually helpful in the diagnosis, in addition to diagnosing seizures. So let's say your child was diagnosed with epilepsy. Now, how do we choose a medication? This is more difficult in patients with autism than it is in the general population because there's a lot of things to think about with different behavioral comorbidities that come with autism. There's not one fix, there's not one medication I would recommend in children with autism more than other children, but you really have to take the patient into the whole picture. Based on what type of epilepsy they're diagnosed with, if it's focal, if it's generalized, if it's a syndrome, that's of course the first thing that we're going to look at to help guide us on which medication we choose. But this is kind of a list of things to kind of think about when you're picking a medication that might really impact the patient's behavior. So consider behavior. If the patient is aggressive, irritable, prone to sadness or depression, you might consider avoiding levetiracetam because this can worsen things. You might consider reaching for a medicine like lamotrigine or valproic acid because those can stabilize mood and make things like depression, irritability, behavioral comorbidities even better. Just something to think about. We also want to think about compliance. So there's a medicine called lamotrigine that you can't miss multiple doses of this medication and just keep going. You have to start back at the beginning because there's a high risk of rash. So if there's a chance that the patient's going to only be intermittently getting this medication and might go for days at a time refusing to take it, we don't want to start this one. Think about appetite. A lot of our kids are really picky eaters or don't eat very much. They already have kind of an appetite suppression. So you want to avoid zonisamide or topiramate if they have appetite suppression. On the other hand, some of our patients, only eat pizza, French fries, and mashed potatoes, and they might be overweight. With those patients, you might actually consider trying one of these medications, and you might want to avoid valproic acid. Blood draws. Some children with autism are perfectly fine with this, and some it's such a fight to get blood drawn that you might just want to avoid medication for that reason. And so a lot of these do have blood draws, but some of the ones that really require more frequent blood draws are valproate, felbamate, and cannabidiol, CBD. And so you might want to avoid that if the patient's not going to do well with blood draws. And then think about the formulation options. Tablets, capsules, liquids, sprinkles, which the tablets can be opened up and sprinkled in like pudding, and then chewable. If there's one or the other that's going to be easier for your child to take, then think about that, and that might help guide the management. But we have a lot of different anti-seizure medications, and so it's more important to think of the whole patient in kids with autism and making sure that we're not kind of setting it up for failure. All right, so that was kind of my main portion on the epilepsy part. I wanted to talk a little bit about this because children getting diagnosed with autism in the time of COVID, often there's long wait lists. And so I wanted to give you a little bit about my experience with autism. Before becoming a pediatric neurologist, I was actually a behavioral therapist. And so I wanted to talk a little bit about things that I've done with patients and a little bit about the therapies that you might be recommended if your child is diagnosed with autism. So a little out of the scope of epilepsy, but a really important question to address. So one of the common therapies, in fact, the most common therapy that's specifically autism specific is ABA, or applied behavior analysis. Basically what ABA is it's teaching behaviors or teaching good behaviors or minimizing socially inappropriate behaviors. And so they do these things called discrete trials where they'll kind of tell the patient to do something, and when they do it appropriately, they positively reinforce it kind of over and over again. So the child kind of learns that this behavior is appropriate or is good, or vice versa. If it's an inappropriate behavior, kind of learns not to do it. This is a super important aspect of the therapy of autism and can also help with speech, with communication. So many aspects of autism can be really taught and affirmed through ABA therapy. There's another method that you might not know of as much. This is kind of not talked about, I think, as much and kind of an initial diagnosis of autism, but it's called Floortime. Or DIR, the Developmental Individual Differences and Relationship-Based Model. And this is a really cool type of therapy for autism that I've actually been able to participate in with one of my clients when I was in behavioral therapy. And basically, it encourages communication and relationship building and appropriate play by meeting the patient at their level. So instead of where ABA kind of is taking the patient's behaviors and teaching them how to kind of more appropriately fit into our society, this is kind of the opposite. We meet the child at their level, and then we try to communicate with them with what they're doing to influence it to become more appropriate. So for example, let's say the child is stimming and they're just kind of sitting on the ground with their head, on the ground. You might go over to them and incorporate it into a type of play and get right next to them and say, oh, do you hear the train coming? I hear the train coming, and kind of create a pretend play, following their lead and kind of seeing where it goes. Often this is also involves like objects. So playing with things in the room, if they're doing something that's not really constructive or purposeful with a toy, go to them, imitate them, and then evolve it into something purposeful, like making a fort out of pillows or stacking the blocks, but always checking in with them and following their lead so that they are guiding the play and they're actively involved in the play. It takes a lot of learning and reading, but it's a really cool therapy that I'd encourage you to look into if your child is diagnosed with autism. But it focuses on shared attention, social engagement, and problem solving, and always follows the child's lead. And then this one is great for COVID times because it is socially distanced. But hippotherapy or equine therapy is horseback riding, but it's a specific therapy for children with autism and adults with autism. And basically the rhythmic movement can kind of help with balance, coordination, and posture, and also gives good sensory input to the child. And so this is something that, again, is really helpful in the times of social distancing and something that can be additive to all the other therapies that the child might be getting. And then, as we talked about, every child with epilepsy with autism has deficits in the social communication domain. And a lot of this is speech. A third of children with autism, people with autism will never speak. And so it's important to use alternative ways of communication. Sometimes that comes in the form of PECS, which is the Picture Exchange Communication System. So this is an example of these. They're little laminated pictures that the child can use to say what they want. And it really helps put things into their hands. So they, instead of just grabbing your hand and pulling you to something, it forces them to use some sort of communication that's more socially acceptable. For example, with someone who's not their parent and really used to them to like point and say, I want this cookie. And this can kind of develop from there, from going from just picking the picture to actually creating full sentences with the picture exchange communication system. And that's evolved now in the time of technology. A lot of this is used on a tablet or different augmentative devices where they push a button and they can create the sentence, and they push the button and the sentence comes out of the computer. So it takes away the anxiety and difficulty of making the words themselves. So this is a very important piece, and something that if you're on a wait list, you can kind of start doing at home. Of course, you may not be trained like a speech therapist is, but it gives the child the ability to communicate and really helps them feel more autonomous, and often really helps behaviors because they're not as frustrated because they can't communicate. So I've been getting this a lot. Okay, great. We have this diagnosis. Let's get started. We're on a wait list. So I just wanted to talk a little bit about things that I've done in my career. It's very patient specific, but some examples of things patient specific that you can do at home to kind of already start some of these therapies if you're ready to go and you're sitting on a wait list. First and foremost, check out autismspeaks.org. There's something on there called the First 100 Days Toolkit, which is an amazing resource for parents, caretakers, family members of someone who's newly diagnosed with autism. And it has a lot of resources on there for different ABA therapists or other therapy in your area, in your region. It's a wonderful website. Definitely start here if you're questioning autism or have a diagnosis of autism. Sleep is a big part of autism, as well as daily routines. And it's so important that the child has expectations for what's about to come. And so this is an example of a routine board. So to let the child know, okay, we're putting our pajamas on, then we go to the potty, then we wash our hands, then we brush our teeth. This can be used in the home, in the school. This can be used in any aspect of the day to kind of prepare them with pictures instead of verbally about what's about to happen. So they kind of know what the next step is, and they can even pull off the picture at each step so they know what's happening next. And for our more advanced cognitively and verbally children, I use this with typical kids too, but a bedtime pass. So if we're having trouble falling asleep, you can say you can use your bedtime pass for one thing, if it's a hug or a drink of water or something. But if you don't use it, then the next day you get a little reward, like a sticker or something like that. But sleep is really common in autism, and there are a lot of behavioral ways that you can treat it before thinking about medications. The first then board is really important about indicating to patients that first we're going to do this really fun thing, and then after that we have to do, you know, our work, or vice versa. First finish your work, and then you get this reward of like playing on your tablet. Again, it's an indication, especially kind of down at the first level when they're just kind of learning about these pictures, to say first we do this and then we do this, to kind of prevent the temper tantrum that might happen when all of a sudden the routine is changed. I wanted to show this as an example. Elopement is frequently an issue with autism. Children who, when they're scared, sensory overloaded, upset, just run away. They don't tell mom. They might run into the street. You know, it's a very dangerous situation sometimes in kids with autism. And we had a child who would get overwhelmed and would just run away. Even though he was pretty verbal, it was too much for him. And so we just made a stoplight at home. We cut it out of construction paper, and we had a green light and a red light. And every time he wanted to go outside, or he would have to bring us the green light. And then we started bringing it, you know, to school, and we brought it to the grocery store. And then we just implemented over and over and over again. If you need to go away from mom for whatever reason, you have to show her the green light. You don't have to tell her what's going on, but you have to come bring her this light so that you've touched base with her before you run away. Then there was another patient I had who would just become overwhelmed when they were upset and just start having a temper tantrum. And sometimes we wouldn't know why. And sometimes it would be physically aggressive, and he would kick or hit his classmates or his siblings. And so we created this kind of stepwise thing where we just talked about emotions, because it's a really abstract thing for children with autism to think about. He loved to play the game memory. So we just started using these and played memory, where you turn them over and you find 2 happy cards and then you get a point. And then from there, anytime you'd get a match, you had to come up with the time that you might feel one of these emotions. That was extremely difficult for him. But I would give the examples. And then at first he would just use the examples that I'd given before. And over time, as we kept playing, he was actually able to come up with some of his own examples, which was so exciting. And then we created a board, a feelings board. We used these images, and when he would get upset about something, I would run over and grab the board and put his hand on the upset one, or frustrated or mad, and indicate like he has to show this to us to let us know, instead of kicking, his classmates. And then over time, he was able to do it himself. So this took many, many months for us to do. And obviously it's best done, with a therapist kind of helping you, but I just wanted to give some examples of things that you could think about in the home that's patient directed, to kind of help them kind of learn something and do more appropriate behaviors and communication. So that's it. I thank you for your attention. And if there are any questions, I'm happy to answer them.
It's not looking like anybody has posted any. I had a few questions from here's a question. Let me get it. I was going to say I had a few questions myself, but you answered them. When should a parent with a child who has ASD, epilepsy, or other comorbidities and is medicated with an AED and a stimulant discuss medication change when behaviors become problematic?
That is a common scenario.
And the seizures are under control.
Okay. So seizures, let me see if I can pull up to just kind of read it again. So seizures are under control. We're on a stimulant and an anti-seizure medicine when discuss medication change. So first of all, a common question from all comers is, we're on a stimulant, we're on an anti-seizure medicine, we have epilepsy. Could this stimulant worsen my seizures? And the short answer is yes, but very, very uncommonly. In some of the studies that they did when they were looking at stimulants, seizures were something that they found in the patients. And so it's kind of listed as a side effect, but I've seen it extremely uncommonly. And so typically, if the patient has ADHD and needs difficulty, has difficulty focusing, I'd say still try the stimulant. And if you see an increase of seizure frequency that's pretty clearly related to it, then you can pull back because it can affect development and learning so much that I always say it's worth trying because the risk of seizure is so low. As far as when behavior becomes problematic, it's really patient dependent and medication dependent. And so the medication levetiracetam, that one is notorious for behavioral issues. And so they're usually dramatic. So I tell my patients ahead of time, if we're going to start this medicine, levetiracetam, and your child completely changed, it's like flip a switch, then there's a good chance it's the medication, and I'm probably going to change it. If they've been on it for a really long time and all of a sudden, yes, it is real. I'm avoiding the brand name, but that rage is real. If they've been on this medication for a really long time and all of a sudden behaviors are a little bit worse, I'm a lot less likely to blame it on the medication. That one's the most notorious. I mentioned in this talk valproate or valproic acid and lamotrigine are two that are more common to kind of help behaviors and kind of calm things down. So if they are appropriate with the patient's other comorbidities and with their type of epilepsy, that's something to think about. But any of these medications can change behavior because they work on the brain. And so even if it's not a most common side effect, if a parent tells me they are different from when we started the medication to stop the medication, I'm going to listen to that because the parent knows the patient the best. And almost any of these medications, you can see it, and it's worth thinking about, especially if it's a change once the medication was on board. Okay, so I see this question. I have two autistic sons, the older one that has intractable epilepsy and ESES. Does that put my younger son at even higher risk of epilepsy? Genetic testing, whole exome hasn't given any answers yet. They've looked at studies on this, patients with autism, and just like the rest of the population, having a family history of epilepsy does increase your risk of epilepsy. And in autism, again, they saw that variable was true, that a family history increases the risk of epilepsy, even if the other patients who had epilepsy were not autistic. So it's hard to answer and say for sure, but I think the short answer is yes, because the sibling has autism. It's very possible that they have the same underlying gene abnormality. So I would watch your other son even more closely for signs of seizures, but it's certainly not a definite yes. It's just kind of another tick that says, oh, if the brother has autism and epilepsy, the other one might too. Have you seen kids on the spectrum who are nonverbal respond to lamotrigine, especially where language is involved? I've had this question asked about a few different medicines, actually. The other one was oxcarbazepine, which is interesting because they're both sodium channel drugs. There's nothing really, there's nothing in the literature that really says definitely these medications will enhance language and development. But that's, I think, one of the key questions in autism is treating the EEG. Could treating the EEG help them? And as of right now, we think that's no, but I wonder if having more spikes, if we might ultimately find that could be helpful. And similarly, if we use specific medications to temper down the spikes and to stop the seizures, could language improve things? So I've heard this. I have not personally seen it happen. I did have one child that we tried oxcarbazepine. We chose oxcarbazepine based on the literature we saw, and it didn't really seem to have an impact. But I think this is certainly something to look into in the future. Are certain medications more beneficial in autism than others? Did you have more questions, Brad?
I'm hoping somebody else has questions for you, but you've answered everything. This was amazing presentation. I plan on sharing this recorded presentation with so many families that we have through our event, as well as in my professional business working in the autism community. This was excellent, really excellent.
Well, thank you. Thank you for your attention. Thank you for joining, and people who'll be watching in the future. Thank you for listening.
Thank you. Happy to have you, Doc.
Bye.